The session now is open for questions for all speakers, including Dr. Arbyn. I have a question, if nobody is going to come. Natalie has a question first, so let's.
Well, thank you. I'm sorry because I just heard Marc's presentation, but I'd like to ask you two questions. I'd like to hear your thoughts about that. First is, you mentioned on your last slide that European countries and US had not an organized screening program, but though you demonstrated that it had an impact on cervical cancer incidence. So there is a little bit of disconnection there. That would be interesting to have your point. Do you think that we would have the same results without any screening? And the second, I would like to have also your opinion on what do you think of the efficacy of HPV screening in countries with a high HIV prevalence? Do you think you would have the same impact? Thanks.
Thank you for these two pertinent questions. Yeah, I did not say that opportunistic screening is not effective. It is effective if a certain coverage and a minimal quality can be assured. And certainly in the US, there is quality assurance and there is a reasonable participation rate. In other countries, in France, Belgium, Austria, where non-organized screening is in place, it is widespread. In Germany, the yearly screening is still the recommended policy. We see a clear impact, but the efficiency, if you see the impact in reduction of incidence per unit of cost, or an equivalent per 1,000 smears per year offered, you see a clear difference. Then your second question, should HPV screening also be implemented in situations where there is a high prevalence of HIV? My answer to that is clearly yes. But policies might be adapted towards more intense screening, earlier starting of screening in HIV positives. But it will not be easy to distinguish the HIV positives from the HIV negatives. This is an important practical public health problem. But yeah, you should also screen there, and certainly in those countries, and we see in Africa, the burden of cervical cancer is clearly related not only with HPV prevalence, but also with HIV prevalence.
Marc, hello? Can you hear me? Yeah. Marc, my question to you was, well, for a couple of comments. First of all, you say in an organized screening program, there's less overscreening or more overscreening. But I would argue that one doesn't really measure overscreening in organized screening programs. You know, you don't know who is being overscreened because they have the opportunity to go to an opportunistic screening program in some of the European countries. I was wondering if, you know, there's some kind of movement going on, because I see overscreening, it's really an interesting issue because it exists in low resource settings, high resource settings, and we want to try to improve efficiency. And I was just wondering if there's any movement to measure overscreening in European countries.
Now there are more and more countries that have established screening registries. Also, countries have done efforts to obtain data from health insurance databases where the individuals can be identified and the success of multiple smears over a short period can be documented. So overscreening in certain countries, even in non-organized countries like in Belgium, we are now able to identify women who have more than one pap smear over 3 years, and we can document the overscreening quite exactly. And I think for non-organized countries, this is a template. It should be followed more. It requires, of course, a lot of discussion regarding privacy and the connection of databases from different health insurance institutions. but it identifies the overscreening. Now, in my presentation, I have described organized and non-organized screening, but often there are mixed forms. And in Finland nowadays, there's even more non-organized screening than organized screening. This was not the case in the 1970s, but gradually, maybe the adherence to the European Union with more liberal health policies have contributed to that. But there are countries like the Netherlands, who screening is almost completely organized and opportunistic screening is almost non-existing.
Next
I just
question.
want to find out from Dr. Carlos on VIA-based type of screening. One of the concerns is quality control. And you talked about, nurses screening people maybe far away from centers where they can be observed. What we've noticed is as much as you can have an aggressive training, if a nurse is not monitored in a few months, you find that their accuracy starts going down with the decisions that they make from the time that they got trained. What are some of the things or systems that you've put in place to make sure, because those are the concerns that go with VIAs, that people are just screening on their own and you're not sure of what type of treatment or how they're making their diagnosis. My second question is on the HPV based type of testing. I believe it's really not more about the tests, but it's the systems that you set up for screening. And you can have pap smear, you can have HPV DNA testing, but if you really don't have the way this screening is going to be done, then you find that HPV DNA testing is really not working the way you thought it should. So what are some of the preconditions or what should be done in countries which are doing VIA testing or any other testing as we move on to HPV testing, which is one of the recommended testing? Thank you.
Both are for me. Okay, for the first question, I think it's important to select the candidates for being trained as primary providers of VIA. You look for people that is in a place and they will be capable of reproduce or start practicing VIA and cryotherapy immediately after the course. Because if they go up and it doesn't start practicing VIA and cryo, they forget everything we have learned during the course. There is no universal quality control methodology about VIA. This is kind of controversial, but in our experience, we have developed a very well-established, validated system of supervision. After a number of months of practicing, we go and we have special tools, forms developed in order to reassure about the quality of VIA they are performing when they go back to their original places. But we're convinced that in a nationwide program, it's very hard to supervise every place where they practice VIA. So that's why we have started working with Colombian people from the National Cancer Institute in Colombia, with Raul Murillo and other people. They have a very good virtual platform for teaching, for training about cervical cancer prevention. And now we're working with them with the support of PAHO, trying to improve that virtual tool in order to use it as a quality control tool. I think it's possible to establish a virtual quality control system in order to be sure, to test how the quality is maintained in every place, even remote places, and also to try to retrain or to improve the quality of VIA practicing. About the second question, it's difficult after HPV positivity to select the best second test. But I think in many parts of the developing world, VIA will be the most practical option because allow us to perform see and treat using VIA and cryotherapy. Of course, it's not the perfect methodology, but usually this first test should be highly sensitive. The second test should be highly specific. And then the criticism is VIA as a second test is not very specific. Cytology is very specific, so cytology would be ideal, but some methods that have a relatively low specificity will work better if we focus on a subpopulation with high prevalence of disease. And after HPV positivity, the universe will be reduced to 10%. And it's a population with a high prevalence of disease because all of them are HPV positive. So the yielding of VIA will be improved. We are convinced of that.
Okay. Well, with that, I think we want to applaud the speakers again one more time. Thank you so much.